Tonight, we're very privileged to have Professor Tamsin Ford from the University of Cambridge, and she is going to be talking about the interrelationship between mental health and education. Obviously, it's a very topical subject, but also something that we perhaps don't know enough about as to how we might work together more effectively, or importantly, how the research informs the interventions and how the interventions work within the context of the classroom, the school, and interact with other agencies. One of the strengths of Professor Ford's work is it is interdisciplinary and transformational as well, looking at the research and its relation to practice. I'm not going to say anything more about that, except we are privileged. She is a world-renowned expert in this field and certainly one of the pioneers in the work. So Tamsin, can I pass over to you to do the presentation? When we get to the end, there will be some Q&A, which we'll pick up from the chat. So please put stuff in the chat. And the final thing is to just warn you, we are recording the seminar and it will go up on the Learnus website and its YouTube channel in the next few days. Okay, over to you, Tamsin.
Okay, I'm hoping that you can all see my screen. Derek, can you just wave at me to confirm that you can see my slide? I can
still see your screen, yes.
Brilliant, wonderful. Once I was giving this lecture and it was moving on my slides, but not on anybody else's. So Derek, can you just keep an eye out for that and wave to me, and I have a solution if that happens. But it shouldn't do. It's only happened once. So good evening, everybody. My name is Tamsin Ford. I am a child and adolescent psychiatrist by my clinical background and an epidemiologist by my research background. And one of the good things that has come out of the dreadful pandemic that we're living through is I no longer have to explain what an epidemiologist is. However, my focus is the epidemiology of mental health conditions in children and young people throughout the entire population, rather than just the children who might come and see someone like me in a clinic. So I've just moved the first slide on. Did that go forward for you, Derek? Fabulous. So we have had a series of very large, very good morbidity surveys funded by the government to ask the question, how many young people are there out there with an impairing mental health condition? You'll see on the slide, the term used is psychiatric disorder, which may kind of stick in the craw a bit for some of you. I'm using that term because that's precisely what was measured according to the International Classification of Diseases, the 10th edition, published by the WHO. And one of the things that makes these studies stand out, if you see at the bottom of the slide just how many children there were, and these are all 5 to 15, so we can compare because that was the age group of the first survey. In fact, 2004 went up to 16, and 2017 extended down to the age of 2 and up to the age of 19. But anyway, these are the 5 to 15-year-olds. Every single young person selected very carefully to reflect the British population. It was a very carefully constructed sample called a probability sample. Had a multi-informant standardized diagnostic assessment. So that meant face-to-face interviews with their parents, always, although in the 2017 survey, those who were 17 or above were the index person, not the parents. And then if the child was 11 or above, they were interviewed directly with these very standardized assessments. And if the family agreed, we mailed a briefer questionnaire to their teachers so that we had very structured information that just related to the things that we need to count to fulfill the research diagnostic criteria. But if there was a problem, we asked the parent or the young person or the teacher to describe the problem in their own words and how it affected the child and what they'd done. And then a series of clinicians, which I have to say, I've been involved in all 3 surveys doing this, put the information together as we would in a clinic to make the decision that does this child have significant problems that would warrant treatment in an NHS clinic? They have to have impairment as well as difficulties. And that allows us to deal with the situation where we know our diagnostic systems are imperfect. In fact, they are for any conditions, not just mental health. But I think because we use things like anxiety and depression, and I'm a bit OCD in common parlance, that actually we get muddled up when we're talking about anxiety or depression as a normal experience of human life, anxiety or depression that's becoming a bit of a problem, and anxiety and depression that's a clinical condition. I want to assure you that when I'm using the term mental health condition or psychiatric disorder, I mean the latter. I mean a child that really obviously needs support. And the first thing to notice is that there has been a gradual deterioration. It wasn't as big as everyone thought it was. We still rather I think not entirely helpfully hear about tsunamis and mental health conditions and a lot of lurid headlines, but there has been a slow and steady deterioration in the mental health of our school-age population. The other thing I want to point out is that one of the most common mental health conditions is conduct disorder. Now, we could talk for an hour, probably more actually, about whether that should be a mental health diagnosis and how much the child's behaviour reflects an environment that's not meeting their needs. And I suspect we would all agree much more than you might initially expect. That said, if you meet these diagnostic criteria in childhood, your outlook is very, very negative in terms of health, employment, criminal justice. And if it was sort of 1 in 20 children, so 1 or 2 in every classroom who had cancer, we would be doing much more about it than we actually are. Now, what you see on the graph in front of you is the 3 surveys, 99 along the bottom of the graph, you've got the years, so 99, 2004 and 2017. And to show you that most of the increase in difficulties is actually around emotional disorders. So what I mean by that is clinically impairing anxiety and depression. Of course, we have had the pandemic. Now, children are not very at risk from getting COVID. They seem less, certainly primary school age children seem less likely to contract it in the first place, and if they do contract it, they seem to be less severely affected. But there have been a handful of cases of a very rare autoimmune disorder that has hospitalized some children. I don't think we've had any deaths in this country, but there have been in other countries. And of course, the restrictions on education and on family life have been intermittent and for some families very severe. So when I say probable mental disorder, we were using a questionnaire here, not the detailed multi-assessment diagnosis I talked about before, because in the scramble from March to get a survey out to children in July, we didn't have time or the funding to do that at that scale. But we invited all of the children and their families who were willing to be contacted again in July of this year to fill in a questionnaire called the Strengths and Difficulties Questionnaire. And that, when you have parent and child, which we did for the 11 to 16-year-olds, allows you to combine the information from both informants, and it will run with either the child only in the older teenagers or the parent only for the primary school age children, to give you probable, possible or unlikely disorder. Now, obviously, we can't compare apples and pears, so we had to do the same thing with 2017. And what we've seen between 2017 and July last year is an increase in the number of children with disorder from 1 in 9 to 1 in 6. So if you think about your average class of 24 to 30 children, that's, 4 to 5 children meeting probable disorder. In a population sample, if you went on and did the detailed psychiatric assessment, you would probably find a half to 2/3 of those would meet diagnostic criteria. We should be very worried about that because a review of 3 cohorts, so one born in 1970, the Alsbach cohort from around the Bristol area, who were all born in the early 1990s, and then the Millennium cohort, who, as it says in the title, were born around the year 2000, the outcomes for the latter cohort are worse than they were for the previous 2. So we have a bit of a worrying problem of almost certainly deteriorating mental health and possibly greater impact from it. However, it is still true that the majority of our kids are doing just fine. I thought it might be useful to whiz through some characteristics about what we found in 2017 to orientate you to some very typical results. This gives someone like me confidence that our survey was accurate. So we found that mental health conditions increased with age, and in fact, if we'd gone on into adulthood, it would increase further. That's totally expected. We found some differences between boys and girls. So boys are overrepresented or more likely to present with difficulties in early childhood. It kind of evens up in secondary school age and then accelerates with girls, as you can see, in the teenage years. And actually this and several other national surveys indicate that we should be really worried about our older teenage girls at the moment. The rates of anxiety, depression and self-harm on all kinds of metrics are really very shocking. And this gender difference is partly because girls and boys have a slightly different profile in terms of what kind of difficulties they tend to present with. So in the primary school age, you will get more behavioural disorders in light blue, more ADHD in the maroony colour, and the less common disorders in this age group is likely to be tics. You know, Tourette's syndrome at its most severe, but other neurodevelopmental problems. Whereas when you move towards adolescence, you start getting eating disorders, anxiety, depression, self-harm, all the things that are more common in our young women. So our green paper, which interestingly hasn't become a white paper, but they are piloting and seem very committed at governmental levels to increasing the collaboration between schools and mental health services, is suggesting that schools should take a lead role in identifying children with mental health conditions. So a young researcher with me when I was in Exeter, and actually working with me now, but still in Exeter, collaborating with colleagues there still, called Frankie. She analysed the 2007 data, comparing concern that a child had a definite or a severe mental health condition in the teachers against whether in 2004 they had a condition according to this complex diagnostic instrument. And what I want to highlight is teachers are very, very good at assessing good mental health. So the negative predictive power is if the teacher says, no, there's not a problem, how likely it is true that there's not a problem according to this diagnostic assessment. The specificity is a slightly different way of looking at the same thing, but I think it's more interesting for you in practice to think of, well, if I think there's not a problem, how likely is there not a problem? And you can see it's almost perfect. However, the positive predicted value, so when a teacher says, I do think there is a problem, you can see it's much lower. Now, that's not because teachers don't know their children. They're right. The children they're worried about who don't have a mental health condition are doing consistently worse than the children that they're not worried about. So what you see here in dark blue is no teacher concern in 2004, a year later, 2 years later and 3 years later, and where teachers are concerned, and this is the average score on the Strengths and Difficulties questionnaire, which is just a general measure of mental health conditions that gives you a score. A high score suggests worse mental health. And so, you know, teachers are right. The kids they're worried about are not doing so well, but they don't have a mental health condition, all of them. And that is because there is no big disjunct between the children who have a mental health condition and those that don't. Now, that doesn't mean to say that mental health conditions don't exist. It's exactly the same in pretty much all kinds of medicine. So to take two obvious examples, asthma. You have, if we got everyone to breathe hard into what's called a peak flow monitor, we would end up with the same kind of curve, with some people with the lungs of an athlete and some people really quite impaired, and most of us right in the middle. But there comes a point at the low level of function where you have a condition. It's the same with diabetes. It's actually the same with cancer. We talk about stages of cancer, but actually it's a spectrum of how abnormal your cells are and how aggressive it is. It's not this nice category. We categorize it because we're not very good in thinking at wide numbers. And sorry, I didn't mean to click, I'll go back. When you meet a child who's scoring here, and this is the self-report, the parent report, and the teacher report, when you meet a child who's scoring right at the extreme end, who has a mental health condition, you know, if you've ever sat with a child who has severe ADHD or autism, there is, or is in the middle of a panic attack, or is so depressed they can hardly get out of bed and they can't wash, and, you know, there is no doubt that this person is severely impaired. But of course, the trouble comes at the borderline, which will be round about just below 20 for the for all of these. It varies slightly depending on who is the informant. And there are psychological and social issues that play into this, as there is for the whole of medicine. It's just if someone's whizzed into casualty in a blue light with a heart attack, it's not the time to say, why is this person presenting in cardiac arrest at this moment in time? There will be biological, social and psychological factors playing into why that person was predisposed to develop heart disease, why it was precipitated at that point, what might keep them unwell. So all the kind of things you do when you formulate a mental health case, actually the social and psychological play into all of medicine. It's just there's more of a focus on it for mental health. And actually those psychological and social factors can make the difference between a child being able to cope and function and develop to their potential in the face of difficulties. The other thing, as an aside, as an epidemiologist, I find these graphs fascinating because the questions, if you've ever seen the strengths and difficulties questions, they're exactly the same. And so teachers don't like reporting problems. Remember, low scores are better functioning. So everyone's squashed up against the better functioning end. And I think that says to me that when teachers say there's a problem, I need to listen. And, you know, the only difference between the parents and the teachers is the P and the T in the corner of the form. It's literally the same question. So where do people go for help? Well, we have consistently shown with these surveys that actually teachers are a de facto frontline service for mental health. And yet we don't, teachers and schools, we don't train the staff working in them to do that. And you know, I think the green paper is spot on. We absolutely need to be working closer together in order to manage this. And just to demonstrate, this is data from my PhD years ago, when everyone thought I was mad. Why was I looking at this? And it shows those with disorder, but also those without disorder. Teachers were the commonest people consulted, but actually as many went to specialist educational resources as went to mental health. And we showed exactly the same thing In 2004, looking forward to 2007, the data is presented slightly differently here. And it shows that, you know, the burden is related to the severity of the disorder. And I should say, actually, of those children who fulfill diagnostic criteria at baseline in these first two surveys, half of them also fulfill criteria 3 years later. These are often not transient difficulties. These children don't do particularly well. And there are costs to that. There are opportunity costs in the staff time, and there are costs to other pupils, and there are costs to the young people who are affected themselves. So one of the obvious places where there is a big interface that I think we need to do much better on is in relation to special educational needs. So about a third of those in 2017 meeting diagnostic criteria for a mental health condition also had recognised special educational needs. This was on parental report. Now, the other disorder here will be mainly children with autism spectrum conditions. There weren't sufficient of them to pull them out as a single group. And you can see children with ADHD, and I can't imagine a mental health condition more likely to impede your ability to cope with school. 62% of them were identified as having special educational needs. That, I think, is a good thing. These are vulnerable learners who are at huge risk of negative outcomes, and it's good their problems have been recognised. Children with mental health conditions were overrepresented in exclusion, particularly children with ADHD, and that chimes with other work that I've done.
The thing is, when a child gets excluded, as a parent, you feel as though you failed. Well, I certainly did, and I think a lot of people would think I failed as a parent. I brought up a child that can't go to school without being excluded. So you don't necessarily want to talk to people about it, and you don't necessarily want to talk to school about it because you feel they may judge you or whatever.
For us, it was absolutely heartbreaking. It was, I think, him being excluded felt as if we'd failed him, as if school had failed him, as if we'd let him down by not either advocating for him enough in school or by not moving him really. So he had a positive end to his primary schooling. It was absolutely horrible, really, really horrible. Exclusion as a word is quite negative. The connotations of it are quite negative. The fear as a parent is that something of starting a journey of problems.
Those are the words of parents that we interviewed as part of a study called SKIP, where we systematically studied in the national survey in the Ausbach cohort. Now, these were children born in the early 1990s, so they're all through school now, and I'll present some data on them later. But also we collected our own sample of children at the point of exclusion and did a battery of mental health and attainment tests on them. Now, in the national survey, their strengths and difficulties score, so their mental health, essentially, remember a high score means poorer mental health, predicted the probability of exclusion, and there is an inflection point at the clinical cut point. Now, this survey allowed us, using two measures, to look at whether or not people were worried, expressing concern, both teachers and parents, about the young person, and whether or not they had a diagnosable mental health condition. So we end up with 4 groups. Those, fortunately, the majority, and it is important to hang on to this, who don't have a mental health condition and nobody's worried about them. Then you've got a group where we're calling them subclinical. So they do have some mental health issues, as I've hinted before. The teachers are right when they're saying these children are not doing as well as they should be, but they don't have a disorder. They're not meeting that clinical impairment threshold. Then you have a group where they are meeting the clinical threshold. They do have a disorder, but nobody's concerned about them. It's the smallest group, which doesn't surprise me. And then you have those where both either teacher or parent, or both often, is worried and they do have a disorder. Now, adjusting for this plethora of background factors when we're looking forward, so these are measured at baseline, as is mental health, and then we look forward to whether or not these children have been excluded 3 years down the line, having taken out the children who had reported an exclusion at baseline. What we see is actually, and it's not what I hypothesized, what we see is the children with recognized difficulties are more likely to be excluded from school. But whether or not it's recognized or not, you are 2 to 4 times more likely to be excluded if your mental health is poor. And there's a bi-directional relationship, both in the national survey data, but also in ALSPAC. So what you are looking at now is mental health trajectory from the age of 3 on the SDQ reported by parents. Those in blue are the children with no exclusions, and those in red are the girls who are excluded. And there weren't very many of them, which is why it doesn't look very different. But actually, if you look at the boys, they are coming in at a higher level and they are decreasing at a much slower level. So this is when we're reporting exclusions. We should be able to see these children coming. So therefore, why are we not putting things in place to you know, if there will be some children who can't cope in a mainstream school, but surely the move should be about meeting their needs and not excluding them. This is the similar data from secondary school. So we've got self-report amongst boys here. And you can see, whilst the boys who weren't excluded by the end of their secondary school, the SDQ does decrease a little bit with age. The paths are diverging. So actually those who are excluded in their secondary school career, their mental health is getting worse. And it's even more marked for the young girls. In our SCIP sample, the sample we recruited ourselves, we actually asked about services and whether or not parents were concerned, and they again confirmed this is not a problem with recognition. We heard a lot in our qualitative study about referrals that hadn't been made because people felt so nihilistic about children actually being seen, schools not being able to cope, long waiting lists, all the things that will be sickeningly familiar.
When you're talking about that level of mental health issues or things that we didn't understand, it doesn't come within our normal realm of how children behave. And it's at that point, I think the frustration is there's no one there to turn to. And well, you know, it's almost the case, well, you have to just get on with it. You're in a school, you do it, that sort of thing.
We know that things aren't right. We know that things need to be better, but there doesn't seem to be support there for that to happen. I think people sit up and take note when you've done an exclusion.
Having the support, timely support available, and a network of people who can guide us.
So those are the voices of teachers we spoke to as part of this study. And I guess, you know, we are seeing exclusions beginning to creep up. We know some of the most vulnerable children are most likely to be excluded, that they often then, their difficulties are compounded by a period out of time. And I would say mental health as well as education difficulties, but also the social difficulties that they can then get into. And I think we really need to think better about this. There's a strong cross-sectional association, and actually we've shown in a couple of data sets longitudinal now between attendance at school and poor mental health. It seems to be, when you look longitudinal, and most data is not longitudinal, that emotional difficulties is associated over time at several time points with poor attendance. But it's not that having poor attendance predicts emotional difficulties, it's the other way around. So in terms of your mental health leads, thinking about ways of identifying children who are who might be struggling with their mental health, don't forget the quiet child who just hides under the radar, and maybe their attendance fluctuates or maybe it suddenly changes. That might be an indicator that there's a mental health condition. the relationships between pupils and staff are really, really important. The 2004 survey had a question to parents about their child's relationship with teachers. And we then looked at these outcomes in 2007, so 3 years down the line. And because we know some children are harder to make relationships with, we controlled for psychiatric disorder and then thought, well, you know, statistical and controlling or adjustment doesn't necessarily get everything out. So let's just take those children out. We did the same for behavior problems and also for family function. We couldn't take family function out because it was a score. So these figures are odds ratios with their 95% confidence intervals. Now, if that sounds like I'm talking Chinese, where it's in blue and italics, that means that roughly the number on the top is how many times more likely a child whose parent reported a poor relationship is likely to have these negative outcomes. Now, there are two columns, because first of all, we just looked at this and then we thought, well, these data were collected halfway through the year. And if we're getting a signal 3 years down the line, then the relationship at the time is going to be having an impact. So we adjusted for the SDQ score. And in primary schools, that weakened the relationship. But in secondary schools, look, even doing that, and I suspect that's over adjusting. So the truth, if you like, is probably somewhere between the two columns on both outcomes. Family function wasn't affected in secondary school, but actually exclusion is. So behavior problems and exclusion are related to how well the staff of the school can build relationships with the children in the school. But teaching is really, really tough. There's very little, you know, we know that a huge number of teachers leave the profession every year, that rates of burnout and stress and mental health difficulties are really high. It's very difficult to find empirical data to support it. So I've examined it in a trial. So in the light blue, you have the teachers in my trial against parents of a managerial or professional occupation, and you can see that the teachers are scoring higher on a depression measure. And you see the same here with secondary school teachers in the WISE trial, which was run in Bristol against a US population study. We didn't have UK data at that point on that measure. And in a trial that had data over 30 months, so nearly 3 entire academic years, 10% of the primary school teachers working with us scored in the clinical range at all 4 time points. So what's the solution? One thing that I've explored in a trial, and actually other people had the same idea, was a way of supporting teachers to really sharpen up their classroom management skills and build relationships from a program called The Incredible Years. And there's a wealth of information on this website, but it was developed for children with severe behavior problems. And the parenting intervention has gone everywhere. Well, that makes sense. You know, if you want the biggest bang for your bucks, you know, get the parents working as best as they can, but that's not going to help problems in school. And some children only have problems in school. And actually, parents can't do very much at the time. You know, the classroom is where the teacher is. So this I am reproducing with permission from Carolyn Webster Stratton, who developed this program. But basically, the idea is that you model and coach problem solving, cooperation, you try and boost self-esteem. There's lots of praise for the behavior you want, and you try and ignore as much that you don't want if it's low level. Obviously, there's some things you can't ignore. That is in the context of very clear expectations. This is not about just letting children do what they want at all, but then the use of non-verbal cues or distracting or, you know, pointing out the child who's doing what you want to do rather than reprimanding the child who's doing what you don't want to do, because adult attention is highly rewarding, followed by very clear sanctions and consequences where if you do that, this happens, both whether the behavior is desired or not. So the program offers 6 days, spaced about a month apart, so the teacher can try out things in their context. And it starts with the bottom of the pyramid, all the kind of more positive stuff, and works through behavior plans to the much more complex stuff.
I think the main thing about STARS was getting you into the frame of mind where you don't always have to pick up on the negatives, and that you're constantly celebrating the good things that are happening, and that's meant to make all the other children realise that you get attention for behaving well, and not necessarily trying to get attention for not behaving well. And in theory, that should make everybody want to behave brilliantly, and it does work. And I think it takes a while to get into that mindset, but the more time I spent going to the course and having the training, the more I realised how it changes the way that you think. And when you come back into the classroom, that you consciously need to think about picking up on positive things, but the more you do it, the more repetitive it becomes, and the easier it is to spot all the wonderful things that children do and praise them for that, rather than focusing on the negative and just almost ignoring the negative things.
So I'll break this rather busy slide down for you. And I should have said, anyone who wants copies of these slides, I'll make a PDF available. So I've talked about the intervention. What I haven't said is for the trial, because I was painfully aware I was a child psychiatrist in a medical school running a trial in schools, I ensured that everybody who delivered, first of all, they were thoroughly trained. They were supervised by Carolyn Webster Stratton, but they all had a teaching background. However, they know that the teachers bring a lot of expertise. So it's delivered in a very collaborative, facilitative model that helps people look for the solutions and try out the solutions that work in their situation. So our theory was that this actually helps the teacher have some time and space to think about the kids that they're working with at the moment, to be a bit more reflective. And actually what they all said to us was it was very validating. These were things that they'd heard before, but they hadn't really had the opportunity for a while to think about them. And that therefore you have a teacher who's feeling more confident, who's more reflective, they're less reactive, they develop strategies around their trickiest kids. You know, if Johnny can only sit for 15 minutes, give him a reason to get up at 12 minutes and congratulate him on how well he's done. And then maybe it'll be 20 minutes down the line. That the teacher is, because they're less stressed, they're calmer. And then for individual children, they are more settled. They replicate this pro-social behavior that they've seen. They emotionally regulate as the classroom is more settled. There are group effects of this. Everyone is clearer about what the expectations are around behavior. The environment is more positive, more work can go on, and relationships improved. And what we hope is that you would see a happier, healthier, better outcomes all round in the school. But of course, there's the context impinging on this, which at the moment includes a pandemic. And we know our most vulnerable children don't necessarily have the best environments. For some, school is a safe haven. So our trial, just very briefly to go through this, was 80 schools across Plymouth, Devon and Torbay, 3 overlapping cohorts because, you know, we couldn't get around 80 schools all at the same time. And we got head teachers to nominate 1 teacher per school in the first 5 years of primary school, so we could follow them up in year 5 and year 6 without losing any of them. So each school was in the trial for 3 years. We went round at baseline, which is really important. So nobody knew whether they were going to get the training or not when we took our baseline measures. Then we randomly allocated, like flipping a coin, the teacher and each school to either get the training straight away or to have it 6 months later. A year later, sorry, the teachers in the training arm went off and had their training, whilst the teachers in the other arm, so 40 teachers, 40 schools, just taught as normal. And then we went back at the end of that year and collected all our questionnaires and did classroom observations on about a quarter of them, as we'd done at baseline. We insisted no mixed year groups so that the children and the teachers separated, and that meant we could encourage the controls to stay with us because they could access the training the next year. And we went back another 2 years following the children with different teachers, because of course, ideally a randomized control trial is blind to who's getting the treatment. Well, if you can blind a teacher to the fact they're going on a course, please tell me how, because we didn't work out how to do that. Just a little aside, for some of you might find this useful, we wanted to have the child's voice in there, so we made a measure that's suitable to be completed with support by 4 to 6 year olds, but certainly by key stage 2, they're able to fill it in for themselves, and it's freely available to download at no charge if you would find it useful. And likewise, we validated these 6 questions, which come from a much longer questionnaire that have been used in the school effectiveness literature over the years. But we're aware that we were getting teachers to fill in these questionnaires on all their children in the class pretty much. So we wanted to get the ones that were most relevant to low-level disruption in school, because the SDQ is a mental health measure. It's not designed to measure what's going on in schools, and it doesn't do it very well. So from our process evaluation, our qualitative data that we gathered about how the teachers experienced it, this is what they said about the impact.
I think one thing I grasp is the idea that we are important teachers, and how much we do mean to the children, and how we can actually make a difference. It's changed me, and I think my relationship towards the children, I take far more interest in them as individuals and far more interest in their personal lives as well.
My whole mindset has changed.
Sorry, twitchy fingers.
I think one thing I grasp is the idea that we are important teachers, and how much we do mean to the children, and how we can actually make a difference. It's changed me, and I think my relationship towards the children, I take far more interest in them as individuals and far more interest in their personal lives as well.
My whole mindset has changed. Everything I've learned at uni, it's not gone out the window, but I think my mindset and my practice and the way I deliver my lessons and my behaviour management has completely changed because of the things we've discussed, the way I've learned from others here. And Ed Psych said, there's no way I would have said you're an NQT watching your behaviour management.
It definitely has more impact, and it leads to, a happier classroom. The kids have confidences up, they're more willing to do things and try really hard. Because if they know they're doing what you've asked them to do, they're going to get the praise, they're going to get the rewards.
So just to summarise our findings on the quantitative measures, so we use the teacher strengths and difficulties questionnaire, the total score, as our primary outcome. We found a small but significant improvement on teacher reports at 9 months, but also on peer relationships and pro-social behaviour. Far more exciting for me as a clinician is we had a plan right from the outset. We hypothesised that those in poorer mental health might do better. And that's precisely what we found, but more importantly, their improvement was sustained over 30 months. We also found on the pupil behaviour questionnaire and the ADHD subscale of the SDQ that classroom behaviour and concentration were sustained in improvements over 30 months too. And it looks like it's cost effective if you're willing to pay for the training. There was something going on. There was a complicated interaction with baseline mental health and academic progress, but for various technical reasons, we didn't have very good measures, and it's quite difficult to interpret, but it was enough to get the Education Endowment Foundation interested in a replication. Our observations, which were conducted blind, because you can blind researchers and encourage teachers not to tell them whether they've been on the course, that did suggest a change in teacher behaviour and improved child compliance. But sadly, we didn't improve the teachers' mental health, their professional self-efficacy or rates of burnout. And we didn't impact the mental health of children reported by their parents or how happy they felt about school. one of the things that came out was that teacher-pupil relationships were really what the teachers thought improved. And they even thought that the impact might be amplified in subsequent years when they could apply the learning to their planning as well as their delivery. And they thought it would be useful to train more teachers and staff, including TAs.
It's a nicer environment to be in, and it's made me think now just about exactly what I say and how that comes across, just to make sure that they are phrased in a positive way, and that I'm not always picking up on the negatives, and that I am praising them when they're doing things that they should be, and that's really helped. I feel happier, and I think they do as well.
I'm not so stressed out anymore. Things like behaviour has helped me in that way that I kind of don't let it get me down when things have not quite worked out. I'll look at it and try something different rather than beating myself up about it.
I think if I had said, is there anyone prepared to now coordinate some sort of behaviour support? Before I would have said no, but now I would say yes, go on then, let's look at that, because I feel like I've got the confidence to do that.
So despite not being able to detect a change, the qualitative data, the focus groups suggest that actually teachers felt they had got a lot out of it. And I have to say, teachers are the most amazing research subjects. They're so diligent, and the number of conversations we had with people, I think we really just didn't have good enough questionnaires. So there is a trial in the field at the moment. 140 schools. We're training all of the year 1 and year 2 teachers. And the idea is that we follow the children who were in reception when we got baseline measures. Then we train the teachers for year 1 and year 2 so that we follow them through 2 years of IY trained teachers in the intervention arm. And we were going to use year 2 SATs, but they're not happening. And it's unfair to our schools to administer tests. So we will be focusing on the mental health outcomes, but we have got a better measure of teacher-pupil relationships in there. Now, at the time I did my trial, several other people had a similar idea. So there was a big trial in Canada and another one in America. And interestingly, we all found a similar thing, that overall the impact on everybody's mental health was not marked, but there did seem to be a really positive, sustained impact on those who are more vulnerable. And we then worked with a team of people with the Education Endowment Fund to produce this practitioner guide about improving behaviour in schools, which is available. Some of you are probably very familiar with it. And I think I just want to finish up by saying, trying to prevent things, we don't have a very good measure for picking it up. So there's this wonderful paper by a colleague of mine, Mark Greenberg, who's emeritus professor at Penn State University. He's done a lot of work on prevention of all kinds of difficulties in children and young people. And the thing is, you're intervening with a group where most kids are doing fine. And then there will be some kids who need my services, clinical services. But between and what we're probably dealing with now as a result of the pandemic is a bigger vulnerable group. And that is where whole school policies about bullying, about the behaviour type of problems that I've mentioned, that's when they can have a real impact and hopefully reduce the group who are vulnerable. I just want to finish up with this teacher. He did not go on the course, but he did inherit a class from a teacher who had.
Okay, so as part of the STAR study, I feel this class in particular, have got a lot more energy and a lot more desire to do the right thing, and a lot more desire to learn. And their attitude towards learning as a direct consequence, I think, of what's been going on as a result of the STAR study. I feel they feel more aware of what they should be doing positively in terms of their behaviour and where they should be. And for young children of 5 and 6 years old, to be in control like that is definitely different to what's happened in the past with similar age classes. So what these guys can achieve, what these guys have done, is significantly different from previous year groups. Okay, I don't know whether that's a result of the STAR study, but we are looking at children here now at this point who are greater control of their own behaviour and make greater progress.
I would just like to thank all the amazing people who've helped me to present, and all the data I've presented is data that I've been involved in collecting. There'll be references for those that want them, and I apologise for waffling on for a bit too long, but I couldn't think what to cut out.
Brilliant. Thank you, Tamsin. Don't apologise for going on too long, because I found it fascinating. I'm sure other people out there did as well. If we just spend a bit of time, sort of any questions and answers, if people want to put it into chat, or given that we've now can see most of you on the screen, if you want to raise your hand and ask the question directly, then we can also try that. If you haven't got questions, it doesn't matter, but I think there's lots of things. But before I do that, can I just warn you, my broadband is playing up and it's going in and out. So if I disappear, just cheer and carry on regardless. That's all I'm going to suggest. Okay. So any questions that people want to put at the moment? But because I've got one that I would like to start with, and going right back to the very beginning. Obviously, the trends that we've seen in terms of increase in mental health and vulnerability, are there any factors that you can identify that seem to have contributed particularly to that, that we perhaps missed along the way?
Well, it's a really interesting question, isn't it? Now, the data I've gathered, and I've helped to gather with the Office for National Statistics, NatSen, and coordinated by NHS Digital. These data are not designed to explain why. Now we have longitudinal data, we will be able to see what at baseline, we've got a huge amount of data like parental mental health, social media use, stressful life events, physical health, socioeconomic status, ethnicity, all kinds of possible explanatory factors. We'll be able to see what predicts the deterioration, and a temporal sort of, having something at baseline that's associated with change sort of starts to point towards causation, but then, the temporal order doesn't necessarily mean that. I mean, puberty comes before death for most of us, but it doesn't cause death, if you see what I mean. So it's really hard to disentangle without running experiments. There are some experiments that just aren't ethical to do. Certainly relationships and your experience, as I've just shown with the STARS trial, can impact on mental health. And we're very aware that whilst we're all in a lockdown, that actually people have described COVID-19 as a syndemic, in that it is impacting heavily along social factors. So if, it's very different for my kids who are in their first year at university, and in fact did their A-levels or not, as it was during the very first lockdown. We are lucky enough to have a house with decent broadband where mostly all four of us can stream things. They have their own laptops, and they have peace and quiet in which to work. If you are in I've visited families where there are 5 or 6 people living in 2 rooms, and somebody's on a phone trying to do their schoolwork. That's going to be a very different situation. And if you have bad family relationships or mental health conditions in either the child or the parent, or sometimes both, it's a recipe for domestic violence, and it's a recipe for substance misuse. So I think sadly what we're going to see is widening inequality, both in terms of health, particularly mental health, and education.
Obviously identifying causation is a big problem, but I think it's interesting that we're now much more aware of some of the things that might be contributing to the situation we're in. And in fact, just something in the chat, someone's raised the issue of a specific issue around maths anxiety, for example. Do you see particular increase in that coming on, or?
Well, I think
separate?
Our children feel very pressured. That's very clear. So in the PISA data on well-being, we do badly. And in the Good Childhood surveys, exam pressures and worrying about doing well at school come through very strongly. And then some of the rapid online, so not representative of the population, but they got several thousand people responding, like the CoSpace study. Again, worries about falling behind at school were very prevalent. And worryingly, there are a group of children who seem to be doing better during lockdown, for whom school is a really aversive place to be. And that should make, we make everybody go to school. So if we are making children go into an environment that's impacting negatively on their health, we need to think about that. So there was an interesting study from the School of Public Health in Bristol, where serendipitously they'd got 1,000 year nines to complete mental health and wellbeing measures in October 2019. So they went back in May, and what they found was those in poorer mental health prior to lockdown were actually doing significantly better, which should worry us, I think.
Interesting, and something to follow up, certainly. Just a question, an interesting one. Does the gender of the teacher have any impact on the outcome?
I think that is a really interesting issue. I think it won't surprise you that the vast majority of our teachers in the study, we had 80 of them, the vast majority of them were female, because that's what you'd expect from primary school. I think it's quite tough for small boys in that school is a very, very estrogenic environment, if you like. It's a very female environment, and it would be great to see more male teachers, so it's a bit more balanced. I don't think it's the gender of the teacher, though. I think it's the relationship. And I think it's about having a strong relationship and being able to work. Children come in all shapes and sizes, and so do teachers. And all of us will have some individuals that we struggle to get along with, but it's about the teacher remembering that they're the professional and doing their utmost to try and keep a positive, constructive working relationship with the child. And I think that stands regardless of gender.
Yeah, no. The other question that comes to my mind is differences between primary and secondary. Are there any suggestions that the impact is different in the age groups?
Well, I think what we're seeing is an acceleration of anxiety, depression, and self-harm in our older teenagers, and particularly our teenage girls. And I think during lockdown, what we have seen is a massive increase in eating disorders, which is probably about the lack of structure and the increased time available for those who are vulnerable to ruminate and compare themselves with others, and then sort of combined with boredom and lack of activity, perhaps to exercise, people putting on weight, then going on diets and then getting out of control. So the number of under 18s who've needed emergency assessment for eating disorders has doubled over the last 6 months, but that's been accompanied by a smaller increase in those who needed routine assessments. And BEAT is a charity that provides excellent support for people with these kind of difficulties. They've said they've had 300% increase in inquiries. So we're seeing more eating disorders in adults as well as young people. But of course, the peak incidence is the mid-teens. So I think you see different problems at different age groups. But the worry about schoolwork is there from the age of 8, when people can self-report. So our children are feeling very pressured, and I think we need to think about assessment in our school system, whether it's fit for purpose and whether it's actually assessing things. What I hear from my colleagues in the university is that A-levels are not helping us pick out the people who are going to make good doctors or are going to do well in degrees. And employers are often saying actually what they need is lots of soft skills. They need people who can problem solve, people who can collaborate, people who are self-aware. And that's not what we're producing with our education system.
I think that is a really big question, but I can't say I disagree. With that, can I just ask one sort of final question? In terms of the intervention, what an engineer would call, what are the tolerance limits? In the sense that you've developed the program that you're trying. Do we know how far you can deviate from that program in order to accommodate the context without it starting to diminish in impact?
That's a really interesting and important question. So I didn't develop the program. I lifted it wholesale from Carolyn West Stratton in Seattle, but just the teacher element of it, because it just seemed like a no-brainer that, the nice recommended treatment for really severe behavior problems for children is the parent program on its own. But when I'm feeling brave, I ask teachers whether or not they think they can get their pupils to tidy their rooms or make their beds. And, nobody yet has said, oh, of course I can. And that's a little bit, I'm being flippant because of course parenting is hugely important, but the bottom line is no amount of training parents is going to impact on a problem in the school environment when the teacher is in charge. And actually, we can only control our own behavior. So if the parent is not there, what the teacher has control over is what they do and how they react and how they set the classroom up. So it's about empowering teachers to do what they can. So the idea is that there are elements, the structure is fairly fixed, but there is choice about how you get across certain elements. So the idea is of adaptation to the context with fidelity to the kind of core curriculum. The same way that you might, I don't know, teach history or social emotional learning or citizenship. You have a curriculum to get through, but actually how you choose to get those points across might vary from year to year or class to class. So
there is room for that variation.
Yeah, it's not scripted. It's not scripted at all, but there are checklists about did you get through X, Y, and Z, and there's a kind of loose structure to the sessions, and I think the order in which you deal with things is fixed. But there is a variety of things, from sort of doing role plays where you get, one teacher to be a child who's misbehaving, another to be the teacher's internal monologue, another one to be the teacher themselves, and you get people to kind of rehearse and role play something. And in fact, one of my favorite comments was from a head teacher who came through one of our feasibility groups, who was always immaculately dressed in a suit and court shoes and never a hair out of place, who sort of appeared sort of rather wild-eyed at the end of one session, and said to me as she left, "Oh, I didn't know being naughty was such fun." And it is winding people up, actually. If you get the feedback, it's great fun. Yeah. And that, I think, was and I went through the course myself to learn to understand it. And I can remember role playing a child who was behaving badly and literally thinking, now what can I do now? And the teacher saying, well done, you're sitting, and actually feeling the kind of, oh, I can't do anything now. It was, even though I knew we were role playing, it was very powerful. So that experiential element, I think, is really important, but there are various ways that you can reproduce it.
Just linked to that, there's a question about, has the issue of attachment theory been linked to the intervention in any way? Somebody's saying that they've had experience.
Good question. Yeah, we're very social animals. Teachers are really important attachment figures. What teachers and teaching assistants do is hugely important. The intervention is carefully constructed out of a number of psychological theories. So there's Bowlby's theories of attachment figure in there. Also, conditioning of, you know, the fact that attention from an adult is really rewarding, so therefore you want to use your attention as a powerful tool on the behavior that you want to see more of, and try, you know, a bit like the sun going behind a cloud, the attention fades when someone's just minor levels of disruption. Also Bandura's theories about modeling and self-efficacy. So yeah, absolutely, attachment is in there because the relationships are key.